So welcome everyone, and thank you for giving up an hour of your evening to attend tonight's webinar on the WorkSafeBC Physician Services Agreement. My name is Sharon Schor. I am the Senior Manager of Communications and Media Relations at Doctors of BC, and I will be your moderator tonight. So you'll be hearing from Mr. Paul Straszak, our Chief Negotiator. He worked with WorkSafeBC negotiating this tentative settlement. You will also hear from Dr. Elliot Weiss, a WorkSafeBC Physical Medicine and Rehabilitation Consultant, Chair of the WorkSafeBC Negotiating Committee, and the Liaison Projects and Innovation Committee. Also tonight we have Mr. Rob Hulick, our Director of Physician Advocacy, who was also involved in the negotiations. So our format for tonight will be as follows. Paul will spend about 10 minutes going over and providing the highlights of the tentative settlement. Afterwards, both he and Elliot will answer your questions. At the bottom of the screen, if you hover your cursor, you should see a couple of icons, Q&A and chat. You'll use Q&A to type in any questions you may have. I will relay your questions to Paul, who will answer them, and Elliot and Rob will add anything if needed. Questions can be asked anonymously if you prefer. That option is in the Q&A box. Feel free to type in questions as Paul is speaking, but I will post them to him in the order received. Even if you don't have a question, feel free to click on the Q&A icon to see the questions that are being asked. And please note that your video and audio are turned off. So if you're having technical issues or other concerns, chat is where you'll let us know. I won't be fielding any questions from chat, just from the Q&A. As a note, this webinar is being recorded and will be made available to anyone who would like to view it later on. I think it should all be pretty straightforward. If you have any questions about the process before we start, just please type it in the Q&A. Okay, so seeing nothing, let's get started. Paul, the floor is yours.
Okay, let me just share my screen. Same screen as before. So what I want to do today is to take you through a review of the tentative settlement that we reached in our negotiations with WorkSafe on the Physician Services Agreement, and to answer any questions that you have at the end. Thanks, Sharon, for introducing Elliot and Rob, who are joining us today. I thought I should also outline, though, and tell you who else was on the bargaining committee. Dr. Colin Jackson, who's an orthopedic surgeon, was on the committee. Doctors Lawrence Welsh and Taki Galanopoulos, family physicians, and Dr. Jen McDonald, who's a medical advisor at WorkSafe. And we are also very ably assisted by Derek Eby and Jorgen Herink from Doctors of BC. So we began negotiations with WorkSafe on this agreement in October of last year for a new contract that will be retroactive to April 1st, 2019. Both parties agreed to delay the start of the negotiations so that we could both conclude our major agreements first. For us, it was the Physician Master Agreement, and for WorkSafe, they sought to conclude a deal first with their compensation employees union. We reached a tentative settlement in August, and I'm pleased to say that both the negotiating committee and the Doctors of BC Board of Directors unanimously recommend that the membership approve the deal. But before I outline the results of the negotiations, I thought I should give you an important insight into the process itself. WorkSafe approached these negotiations much differently than they did in the last round. Last time, the negotiators adopted a very harsh positional attitude in the negotiations, which resulted in challenges at the table and significant conflict between the parties once the agreement was concluded. This time, they didn't use hired negotiators. We dealt directly with the senior director at WorkSafe BC, who's responsible for managing and administering the contract with physicians. And the first priority that he tabled for WorkSafe was to rebuild an effective relationship with us. And that characterized the negotiations process from that point on. As a result, we were able to adopt an interest-based process at the table where we were able to raise and address issues in depth before turning our minds to solutions. As a result, our deal took a bit longer to conclude and is somewhat more involved than the outcome of the previous rounds of bargaining that you may be familiar with. So this slide sets out a high-level overview of the deal. It's a 3-year agreement that has the same term as the PMA, expiring on March 31st, 2022. Like in previous negotiations, This agreement continues all of the conditions of the last contract, with the exception of the specific improvements that I'll be talking to you about today. When we got to discussions about money, WorkSafe agreed that the total funding for fee increases under this agreement should match the deal that we reached in the PMA negotiations. This was a particularly important agreement because in previous rounds of negotiations, the monetary settlement often fell short of the PMA deal. And the PMA deal is special because it's more lucrative than the public sector deals that govern the rest of government settlements in British Columbia. So the total compensation increases to sessional rates and unique fee items over the 3 years of the agreement was about 7.4%, 2.7% in the first year and 2.25% for the out years of the contract. The funding was not all allocated in an across-the-board fashion, but was also targeted to fees that members had identified as priorities to us when we began preparing for these negotiations. The agreement also includes a number of significant non-monetary changes, most of which were targeted to improve the burden on physicians and their staff of interacting with WorkSafe to get timely approvals for services and to understand and confirm appropriate payments. As I mentioned earlier, the monetary settlement includes a mixture of targeted and across-the-board increase. In the first year, all of the fee increases going to fee-for-service physicians were targeted to those fees that were highlighted to us by members. And the total new funding for these allocations equates to an average of a 3.1% increase to base compensation in year one. In years 2 and 3, we agreed to across-the-board increases to all WorkSafeBC unique fees of 2.3% in each of the years. We also agreed to increase the expedited surgical premium from 194% to almost 209% by the last year of the agreement. And we agreed to a 6% increase to sessional rates over the course of the contract. Earlier, I said that fee-for-service physicians in the first year of the contract, the increases to fee-for-service physicians in the first year of the contract would be targeted. For family physicians, we directed the increases to 2 changes only. We established a new rate for Form 8s that were submitted within 1 day after the patient is seen. The current Form 8 rate payment applies to forms returned with 3 days. So we agreed to increase the fee for Form 8s returned within 1 day by $7.70, about 14%. The second change also involves Form 8s. Currently, WorkSafe pays the first physician that sees an injured payment the full Form 8 fee. Now, if that patient is first seen by a physician in the walk-in clinic, that physician gets the full fee. But if the patient then goes to the regular practitioner, who can do a much better job in filling out the form, that physician now gets a reduced fee, about $10 less. It's the Form 11 rate. Under this agreement, if the patient's regular physician sees the patient within 10 business days of the first visit to the walk-in clinic, the physician will get the full payment for the form. So in order for the worker's MRP to be paid the full Form 8 fee, the physician has to first identify as the regular practitioner on the Form 8, and secondly, submit that Form 8 within 10 days of WorkSafe's receipt of the first Form 8 payment. And that will generate the Form 8, the full Form 8 rate for that physician. So the full Form 8 rate can be paid 2 times if the second physician that sees the patient is the MRP. For specialists in the first year of the agreement, we increased a wide variety, a wide variety of fees based on the input that we got in preparation for the negotiations process. We increased 27 unique fees. These are all detailed in the highlights document, which you should have access to, and they include increases to all initial and repeat expedited comprehensive consults, to the fee for expedited consultation cancellation, to fees for medical legal reports and opinions, to fees for return to work planning requests, consultation after surgery, the non-expedited consultation report. And we also increased a range of fees for psychiatry treatments. We also confirmed in the agreement that the fee for anesthesia services will allow for the billing of the anesthesia MSP BMI modifier. This was provisionally agreed to last year, pending confirmation in this round of negotiations, and we did just that. We also agreed to the elimination of one fee that we're informed is unused, a fee for accounts initially rejected by WorkSafe and then later accepted. And we agreed to reduce one rarely used fee, and that's for a Form 8 that's requested by WorkSafe, so that it will now pay the same rate as is paid for a typical Form 8. It's about a $5 reduction. As I said earlier, we agreed to a large number of non-monetary changes, primarily targeting issues related to the administrative burden experienced by physicians who regularly have to deal with WorkSafeBC. The first two changes on this slide deal with the administrative burden related to expedited surgeries. We heard a lot of issues here. Many surgeons reported challenges in meeting the surgical timeline because the WorkSafeBC approval was often issued late, compromising their ability to provide the surgery within the 40-day timeline set out in the agreement. We've now modified the agreement so that the timeline will run from the date on which WorkSafe authorizes the surgery, rather than the date of the last consultation. This will take place once a minor modification is made to the billing system, no later than next January. So once that modification is made, surgeons will be asked to input a $0 code in their EMR the day that documenting the day that WorkSafe authorizes the surgery, and the code then starts the 40-day timeline for expedited surgeries. So that should provide more flexibility and will take out WorkSafeBC's inefficiency from that timeline. Surgeons were also very concerned that the MSP reporting system doesn't make clear the amount that is paid for the expedited surgical premium, making it very difficult for physicians to confirm that they're paid correctly. So WorkSafe has now agreed to work with the top 3 EMR vendors for specialists, with Plexia, with Input Health, and QHR, to ensure that the EMR displays data to confirm this payment. The changes will allow a physician to produce a report which identifies surgeries that qualify for the expedited premium and whether they were billed and paid, and will also specify the total percentage of the expedited premium paid for the surgery. And the system will also include a mechanism that will alert the physician if an expedited payment which is expected has not been made. So this would automatically flag problems through the system rather than require the MOA to manually go through the information to identify those expedited surgical premiums that have yet to be paid. There is, however, a small chance that WorkSafe will find that EMR providers are going to be charging an exorbitant rate for the change. So if they, and if that's the case, WorkSafe has maintained the ability to say, I'm not going forward with that. So if they refuse to pay and implement these expedited, the changes to the EMR, then we will have the right to require WorkSafe to go back to a time-based premium for expedited surgeries. Absolutely, before we go down this road, we consult with our members and get a sense of their view. But as we know that WorkSafe prefers to remain with the expedited surgical premium, this should increase the likelihood that WorkSafe will accept the cost of the EMR changes. And in recent conversations I've had with them, they've indicated that it's highly unlikely that they would trigger the option not to move forward with these EMR changes. So I fully expect that they'll take place. Last item on this slide, we agreed to work with WorkSafe to develop and to pilot a new disability management education program. Its intention is to foster the adoption of better occupational health practices among physicians. The program will be voluntary for physicians, but we agreed that those who adopt those practices that are outlined in the training session will be provided with an additional financial incentive. We haven't determined what that is, but WorkSafe is incented to provide an incentive because of the better quality of work that will be provided. So we'll be entering into that consultation once the new contract has been ratified. And you can see, and you can expect to see a pilot program sometime over the course of the next year. WorkSafe also committed to a number of specific activities that it would be conducting over the course of the next contract to reduce administrative burden. They've committed to work with the medical services plan to improve reporting on complex surgeries and rejected invoices. They'll clarify and simplify requests for consult reports. They'll remove unnecessary fields from forms that are now causing payment rejections. They'll work with us to develop an education program for their internal staff so that they better understand the challenges that physicians experience in processing the payments, and hopefully that will result in an improvement of service. And they've also committed to consult with physicians at the liaison committee on the redesign of forms and on new physician education programs. Also agreed to a number of other non-monetary changes to simplify administration and to clarify the agreement. They've undertaken a commitment to provide better data so that we can better understand the issues that physicians are facing when they deal with WorkSafeBC at an aggregate level and start to take action to address them. We also agreed to consolidate committees under the agreement to simplify our interaction with WorkSafeBC representatives. We've agreed to amalgamate and simplify a number of codes. And we've clarified the payment rules in one spot under the contract in Appendix B, so that physicians can better understand what's required of them to ensure appropriate payment. They'll only have to look in one spot rather than the 2 or 3 spots that are required to make the payment requirements clear. So that's an outline of the agreement. I'm happy to take questions, but I just want to point out that if there are questions that arise after this presentation, you can send an email to Derek Eby at doctorsofbc.ca, and we'll respond to your questions right at that time. So that is the presentation. Very happy to take any questions about it.
Okay, thank you very much, Paul. So we do have a fair number of questions. So as Paul mentioned, if you did not get an answer to your question or you think of one after the webinar is over, please email it to Derek Eby, D-E-B-Y, at doctorsofbc.ca, and he will get back to you. So the first question, does it mean a check is coming for 2019?
The answer to that question is simple, yes, absolutely. For 2019 and the part of 2020 that has elapsed before the payment is made. So it's pretty typical for WorkSafe to cut these retroactive checks because we typically start WorkSafeBC negotiations a bit later than PMA negotiations. But yes, you can expect a retroactive check.
Okay. Does this mean 10 business days or 10 calendar days?
Let me check. I believe it is 10 business days. Actually, I'm going to say it is business days because that's the principle on which we negotiate. 10 days is 10 business days. I'm not looking. I can't see the detail in front of me, but it's 10 business days.
Okay, thank you. Complex surgical procedures requiring a number of fee codes have been hard to bill with the WCB, and the rejections of MSP apply. This does not respect the hours put in or the complexity. Has this been resolved? It was addressed in the old hourly surgical reimbursement model. The current model does not encourage single-stage surgery. It also is hard to follow in the billing, which seems to have been resolved.
Yeah, we haven't applied a premium for time associated with the additional work that I understand that we're talking about here. We have tried to clarify and simplify the process, hopefully reducing the time that is required. And WorkSafe is going to be working with medical services plan, for instance, to automatically process rejected invoices through MSP if possible without having to go back to the physician. So we're trying to reduce the amount of time. I can't say, though, that we have introduced a premium to address the greater challenge that I've heard in the question.
Okay, thank you. These fees don't make up for the years of no increase, and why are you adding more conditions to get money?
The years of no increase would now be quite a few years ago. That's right, we aren't going back and correcting the past. What we're doing is negotiating in the environment that faces us. And so what I can say is WorkSafeBC paid physicians are doing better than the rest of the public sector because we were able to tail off the PMA, which also recognized business costs in the funding that they received from government. So can't say that we're recouping those years that were zero many years ago, but we're doing better than most of the rest of the public sector.
Thank you. There's also a challenge with WCB refusing surgical requests by using retired physicians who failed to do a history and physical and refuse the consent on review of the chart. It's hard to believe that someone not doing a history and physical and non-specialist overrules a surgeon who has seen and examined the patient.
Yeah, I can say we did not address that specific issue in the negotiations, but to the extent that it is an issue that is present and active and relevant, we have a committee, the liaison committee. Rob sits on the liaison committee, Elliot sits on the liaison committee, where we can raise those kinds of issues and have them addressed. But we did not address that in this round of negotiations.
Yeah, Paul, if I can just add, if a physician wants to reach out to us, we have, you can email the same Derek Eby email address, and that will be forwarded on to us, and we're happy to follow up on that at our committee.
Great, thanks. 19953 should always be paid for records requests, not the lower 19904. 19906 fees, as the physician should be reviewing the chart prior to sending info and be paid for it accordingly.
So what I can say is that was an issue that was important for us, and so we've changed the language so that it's very clear to a physician who reads the agreement that the higher fee should be paid anytime a physician is required to review chart notes. So we really only have two fee options right now. A low fee option where it's simply a copy of a report that is being sent to WorkSafe. So the work is not a physician review. The work is photocopying a document. Any other kind of document, a copy of chart notes, is going to be paid the higher fee right now. So that was part of the simplicity that we got to. We eliminated a couple of fees around that issue and made very clear that chart notes, anything that requires a review by a physician, would be subject to the higher fee in the contract.
Okay, thank you. Are there any referral requirements for a specialist to see WCB patients?
I don't know the answer to that. I don't know if Elliot or Rob, you can help me with that. That was certainly not part of the negotiations.
The only referral requirement is ensuring that the consulted physician or surgeon is aware that it's a WorkSafeBC claim. And many of us, what we experience is that it's not identified until we see the patient. And so if we have clarity from the referring physician, there are no limits. Quite often patients have said to me that they're seen through the visiting specialty clinic because the family physician can't refer to a community consultant, but that's actually incorrect. And in fact, I think WorkSafe would prefer in many cases for community consultants to be used to reduce the burden on the visiting specialty clinic.
I can add a little to that. To the extent that there are issues with the referral process, we have a commitment by WorkSafe to take another look at that. The issue we had originated from specialists saying, I got a referral and I didn't know I was a WorkSafe patient, therefore I didn't meet the timelines. So that's one of the things that we want to deal with to see if we can fix in the referral process. But if there are other challenges with the referral process, then let me also suggest that you use that Derek Eby email and highlight them, and we can perhaps bring that into the consultation process on improving referrals.
There's one last dimension to that, Paul, which is, does a physician have a right not to see a WorkSafe patient at all? The short answer is that physicians should see WorkSafe patients. WorkSafe has the obligation around that, and they can refer those matters to the college. But if there are issues around why physicians are having challenges or why they're not wanting to see patients, that's something that we definitely want to hear about.
Thank you. So an addendum to the very first question regarding retroactivity presumes it's for 2020 as well.
Yes. Yeah. Anything we're going to be paid under the agreement as though it was reached prior to April 1st. So anything that's dated before payments go out is going to be retroactive.
Okay. Thank you. Do all these changes apply to all physicians? In other words, are some of the changes only applicable to physicians on the approved provider list WCB has?
So I'm going to take a stab at it, and Rob, tell me if I've fallen off the train here. To the extent that a patient has been referred to a physician, that physician has the right to bill, has the right to bill WorkSafe for the services that were provided. General practitioners are not on an approved list. They're simply the practitioners that are the first point of contact for an injured patient. So I'm not aware of there being an approved list that would limit the application of the majority of the fees in the contract. There are some fees, though, that are associated with personal services agreement. Many psychiatrists are covered by these. And for those psychiatrists, they'd have to have signed on to the personal services.
Okay, thank you. As physicians, we are incentivized to send our reports to WCB in a timely manner. What incentivizes WCB to remunerate this work in a timely manner? Chasing unpaid WCB claims consumes a disproportionate burden on time from my administrative staff.
You know, that was one of the most important issues that we heard from members coming into this round of negotiations. And there are kind of two strategies that we could have used. Strategy number one is to try and impose a heavy financial burden that would cause WorkSafe to move particularly quickly here beyond their own particular interests. Strategy number two is the one that we chose. And that's to start collaborating with them to try and bring the barriers down, to try and educate their staff, to try and ensure that we are more clear on what we need to do to try and take the barriers down that slow us out. There not being enough information, there not being people paying attention. So what we've tried is the collaborative approach to try and reduce the barriers to quick payment.
Paul, if I can just add, one of the other things that we're going to have through this agreement is much more up-to-date information on paid and rejected claims. So we're going to be able to target not only individual fees, but also groups that are encountering more rejections and be able to follow up on them. But if an individual physician is having particular problems with WorkSafe rejections, again, they can contact me and my staff, and we're happy to pursue that at liaison and outside of that. So you can use the same email address, and we're happy to follow up on that. And we have done that for a number of physicians.
Great, thank you. In practicality, isn't one business day an extremely tight timeline for 19908s? If this was agreed to, more of an increase in fees should then be available.
So I'm not all that conversant with numbers. 19908, is that a form? Sorry, Rob, can you help me out with that?
The 19908 is the expedited, non-expedited specialist consult.
I believe they're referring to a Form 8.
That's what I think. Yeah, I think they were talking about a Form 8.
Yeah. So we certainly did discuss that. Actually, right now, about 60% of Form 8s are responded to within 1 day. There's a 3-day timeline, but 60% of them are already responded to in 1 day. So the change that we made to increase that remuneration is going to be a big jump for a lot of physicians that are working quickly. But that also shows us that it's not beyond the pale for physicians to change their administrative process to do that. So we thought it was a great opportunity. While 60% are going to get a big jump, 40% that don't return that quickly will be able to move, will have the opportunity to be able to move more quickly and take advantage of the higher one-day Form 8 fee.
Thank you. With respect to 10 days for the Form 8 for the MRP, you said that was 10 days after the non-MRP submitted the F8, Form 8. Do you mean 10 days from the day patients saw the non-MRP?
No, it's actually 10 days from when WorkSafe receives the information, because they wanted us to count from the date that the visit actually took place. But it seems to me that we would have lost the amount of time it took for that physician then to submit the Form 8. So we got them to agree that they'll start the 10-day countdown from when they receive the request for the first Form 8. And it's at that point that 10 business days flow where the MRP can charge the full Form 8 fee.
Great, thanks. Virtual consults will be very helpful in the management of remote patients. Is this an approved process with the WCB after COVID?
WorkSafe hasn't, WorkSafe made an exception on virtual visits during the COVID period, but they haven't made a commitment as to whether they'll accept virtual fees after COVID is over. So can't answer that question.
Okay. WSBC case managers never respond and are not helpful most of the time, and the physicians are very judgmental and end up questioning family docs management plans at times rather than support us. Is there any feedback mechanism to improve WSBC and to improve our communication with WSBC?
The best feedback mechanism we have is the collaborative committee that we've maintained under the contract. To the extent that there are continuing issues there, what we have as a commitment by WorkSafe is that they're going to try and reduce the barriers to effective processing of claims, and that includes how the parties relate to each other. So to the extent that there are documented problems, we have a mechanism that's available where WorkSafe is prepared to discuss them and try and resolve them. Our sense is that they're quite committed to make the change here because they feel that their success depends upon the support of physicians, or at least that's the message that we got pretty strongly through this last round of negotiations. So I hope that that's a good avenue.
And Paul, just to add, if you have specific examples that you want to reach out to us, again, just please reach out to us through that email address, and we're happy to raise those with them.
Okay, thank you. Patients sometimes report the initial injury report was submitted by the first doctor they saw. Then the MRP gets penalized for submitting the form late when we find out it was never done. Isn't there a way to notify a physician ahead of time the form is needed?
I don't know the answer to that question. It's not something that we had actually discussed in the negotiations. I'm not sure if, Rob, you've got a sense of it.
Yeah, my sense on that is that's an example where the case hasn't been identified as a WorkSafe case and the time frame has gone sort of past for some of the payments. Again, this is an example where either the physician or with our help, we can reach out to WorkSafe to see if there's something that we can do. And again, we've done this in a few cases, but we know that this happens, and it wasn't specifically addressed during negotiations. But again, WorkSafe, to be fair, is interested in making sure that physicians are paid for the work they're doing through this recent commitment from them. And again, you can contact us through the liaison committee if you have case examples of this, and we have staff that would work through this with WorkSafe.
Great, thanks. Is there a dedicated phone number to call now and then to inquire about payment?
I don't know the answer to that.
Paul, I'll take this one. Yes, I don't have it at my fingertips, but there is a phone number for WorkSafeBC that we can provide, and we'll make sure that's on the website pertaining to the agreement around this. And yeah, we can provide that to you. I'm sorry, I apologize, I don't have it at my fingertips.
Great, thanks. During the pandemic, does WorkSafeBC accept paying for virtual consultations the same way that MSP has accepted virtual non-face-to-face consultations?
I can't speak to the detail of the same way, but I know they've accepted them. Both MSP and WorkSafe have accepted virtual rather than face-to-face consultations.
Paul, I don't think I've had any rejected that I've done virtual. And in fact, through the visiting specialty clinic, they're encouraging us to use telehealth rather than bringing injured workers in.
Yeah, and we reached out to WorkSafe when the pandemic hit, and they were very quick to agree to virtual visits. The one caveat that they had added was except in places where a physical assessment is absolutely required. But they've been quite open about it, and they were quite quick to make the change.
Okay, thank you. For retroactive payment, did you negotiate for consideration of interest?
No, did not.
Thanks. It's not rejections, it's pending claims that go on and on and on and on.
I'm trying to recall the detail here. That was a point of discussion in our negotiations. One of the things that we'd obtained is a commitment from WorkSafe to provide more detail on pending claims, so that a physician is aware if the physician has a responsibility to do something to address the pending claim. And that we have as a commitment. I'm trying to think of whether there's something else associated with that. I don't know, Rob, can you recall? I think
the point was around when it was there was challenges in determining whether or not it was a WorkSafe claim or not, and WorkSafe and MSP were taking time to determine that. Unfortunately, I'd have to again go back and look at that, Paul, but I think again what we had determined was trying to make sure that WorkSafe was communicating to the physician the status of the claim and where it was at. But unfortunately, what we heard was that there are cases where it can take months or even longer to finally ascertain the responsibility for the payment of the claim.
But the commitment we have is that to the extent that WorkSafe has more information than just pending, the physician will have that information as well.
Okay, thank you. The expedited fee for surgery assumes surgery in a private facility. However, there are patients that require surgery in a public facility because of comorbidities, size of procedures, or facilities available. There's a fee from the WCB to the private or public facility. Can this be directed to the surgical program in the public hospital to extend the OR day? Otherwise, MSP cases will be postponed to get the WCB case done in a timely manner, i.e., the WorkSafeBC facility fee should not go into the hospital general revenue in a public hospital.
So this goes beyond the scope of negotiations. I do know, though, that WorkSafe has agreements with facilities to pay not just for their responsibility is not simply to pay for physician time, but they also pay a facility for the time and cost that the facility undertakes to permit that. I'm not exactly sure why a physician would suggest that WorkSafe not pay a public facility for time that they're seeking from that facility. So I'm a little unclear on that point.
I don't think we really know what arrangement WorkSafe has with the health authorities regarding compensating the hospitals for the use of their services. And they may have separate agreements that we're not aware of.
Okay, thank you. Why do specialists don't want to see WCB patients? 1, WorkSafeBC payments often are very delayed and require substantially more office staff and physician time in billing and administrative issues. 2, a good proportion of WorkSafeBC patients have possible secondary gain, therefore they are difficult to deal with. They are easily dissatisfied if a specialist doesn't agree or recommend exactly what they want. They leave bad reviews, complain to college or different bodies.
That's absolutely true, and it came out loud and clear when we talked to our members in preparation. 2 points here. One is that we're trying to reduce that administrative burden. That was a major objective of ours, and we think we've made some good strides. We're certainly not going to be, it's not going to be fabulous, but it'll be better after this round of negotiations on the administrative side. On the other side, with respect to the complexity and issues associated with WorkSafe patients, WorkSafe's answer, and it's not a bad answer, is, well, that's why we pay you more. The question, of course, is it enough? And we do seek to get whatever we can in rounds of negotiations and direct money to where our member priorities are, and we try to do that this time.
Okay, thank you. I feel like not seeing WorkSafeBC related issues just because it is too much of a headache with the workload and the pay is not worth it. There's too much red tape which needs to be addressed.
Same answer as last time. Absolutely. It was our intention to reduce at least the thickness of the red tape in this round of negotiations.
Okay. And I think this might be the last question we have at the moment anyway. Assuming TH will continue for the foreseeable future, is there any progress in providing access to online imaging review with private imaging facilities? This would simply simplify consultation and expedite surgical decisions. Simplify.
I don't know the answer to that. It wasn't an issue that was raised in the negotiations. I'm even open to my other co-panelists to provide comments.
Some of the private facilities in Vancouver do have web-based access, but I think the pressure needs to come from the consultants or the primary care physicians to approach those facilities to encourage them to provide digital access, whether it's WorkSafe or an MSP patient. It does exist for some, but not for all of them.
Okay, we have some more in. Simplify consultation and expedite surgical decisions.
Yes.
Okay.
Can I respond to that?
Yeah.
WorkSafe is basically an insurance company, and they're no different than any of the private insurers out there in creating complexity. The problem in BC, or the issue in BC, is we only have MSP, whereas our colleagues in the US have to deal with all these different insurance companies, and that's the nature of the beast. I think we all want our tax money and our WCB premiums to be well spent, and this is the price we have to pay. It's an imperfect system, and WorkSafe have their own processes, and at the end of the day, their priority is to ensure that the injured worker receives appropriate treatment and returns back to work. The cost is secondary, because the real cost to the system is an injured worker who's not working. It's not the healthcare cost. So it's in their interest to expedite and speed up the process.
Just one quick point. We have found the phone number for the payment services for WorkSafe, and it's posted in the chat. Thanks, Katrina.
Thank you. As MRPs, we are expected to be advocates for our patients. If patients complete GRTW by WCB and deemed fit to return to work, but the patient comes back complaining of not being fit to go back, what are we supposed to do? The talks I have had with the WCB physician have not been helpful. Is there a WCB physician who can speak to the patient directly and explain why they are fit to go back? Sometimes I feel like we are put in the middle like the bad guy.
This is an interesting point, actually, that WorkSafe brought to the table. There was a report issued recently which made recommendations, and one recommendation was that a new form would be introduced to allow a physician or a patient with a complaint, and this has to do with actually sort of a long-term award, to be able to introduce new information so that WorkSafe would be able to make a better judgment. So that is actually a narrow answer to a broader question, but there is a new form called the Activities and Limitation Form, which will provide patients representing physicians that are looking at the long-term payments that are made for determinate claims to represent the patient's perspective more fully.
I think one of the roles for this educational program that's proposed is to improve the primary care physician's knowledge in terms of disability management. And we have yet to develop the program. And I think that the issue that's being raised is actually one of the, should be one of the goals in terms of determining whether this program is successful or not.
Thank you. It's not that the money should not be paid to the public hospital. It should go to the surgical program, not general revenue, so that the money can be used to pay overtime so that the room can be extended, not advocating for non-payment.
Mm-hmm. I understand that. So we're suggesting that the hospital use the money in a particular way to benefit the program that's providing the services. That makes a lot of sense. It's outside of our ability to control, however.
Is the retro payment a check or does it come as an MSP payment?
The way it's been described to me as a check, I don't have longer term history here. I can't imagine that it would come through MSP, but maybe Rob, you've got a better perspective.
I think it's a check from WorkSafe is how it's going to come, not MSP.
Yeah.
Okay, thank you. What will happen to expedited WSBC patients when the private facilities are shut down based on the latest provincial Supreme Court decision?
It's going to be a higher pressure to get them done in public facilities, of course. That Supreme Court decision is going to have potentially very significant impacts on access to surgical facilities. Depends how that's going to play out. I think the next step is a potential injunction to be served by Brian Day. That might sort of provide a little bit more time for the case to be progressed to higher levels in court. But once that takes effect, there could be pretty significant impacts, no doubt.
Thank you. If WorkSafe is an insurance company, why are we not holding them to the WorkSafeBC uninsured services fee guide rate?
We have the ability to negotiate specifically for those services, and that's what we do. We do take a look at the uninsured fee. Actually, we do take a look at MSP fees and uninsured rates, sometimes in determining what our proposals are. But at the end of the day, we have to operate within a fiscally responsible framework. It's not within our power to all of a sudden say, WorkSafe, now I want you to double or triple your fees. We've got to operate within a limited envelope, or our members are going to have to try and take particular workplace action. Our intention is to put together a reasonable settlement in the context of the environment. And this time around, what we had was a pot of money the size of the PMA funding envelope. We felt that was a fair settlement, and we redistributed that. Wouldn't be within our power to demand, or how could we enforce such a demand, for rates to be increased very significantly. On top of which, I'm pretty sure that there's a lot of WorkSafeBC fees that don't exist in the uninsured fee guide.
Okay, thank you. I see some patients who decline to report injuries to WCB because of repercussions from their employers and supervisors. Does WorkSafeBC have any help for such people?
The issue did come up in negotiations. We didn't particularly resolve it. I can't recall where it may have ended up. I know, Rob, you've got a great recollection, and I'm wondering if you can add to that.
Not too much, Paul, actually. I think one of the things that, we talked about at the committee is what we can do later on when it's determined that somebody is in fact a WorkSafe patient. I think one of the big challenges is when it goes on for, 30, 60, 90 days before it finally comes out that it was a WorkSafe issue. And there are ways to look at it retroactively, but it's one of those, it's an ongoing challenge, I admit.
Just to comment, before a Form 8 is accepted, it isn't a WorkSafe claim. So a physician and the patient should submit the Form 8 and see how how it falls. Even if an employer is not particularly interested in supporting it, and let WorkSafe investigate that. There's nothing stopping a physician and a patient from submitting a Form 8, though.
Thank you. Is there somewhere we can view the full WorkSafeBC agreement so we can see the details?
Along with the president's letter, and this is also going to be attached to the voting form that comes out through email from Election Buddy, is a memorandum of settlement. I think we call it confirmation of terms of settlement, and we've attached the specific language there. We don't have the fully amended agreement, but we have all of the places that the language has changed, and that's available right now. It's linked to the president's letter.
Okay, thank you. Is WCB a choice? I've been told not, but now it looks like it should be. MSP is actually a choice. We can be completely private. Does MSP participation require WCB participation?
The requirement I'm aware of for WorkSafeBC is that there's a requirement upon a physician to provide a form that starts the process. So the Form 8 is backed up by a legislative requirement. A physician is required to fill in that form and provide information on a form as determined by WorkSafe. My understanding of the rest of it is that it is voluntary for a physician to decide to expedite surgery. And that's the reason that the rates are provide an incentive for physicians to participate, for surgeons to participate to expedite.
Okay, thank you. Is it fraud to bill MSP for services that are really WCB, as we do when WCB rejects? Are we the police to demand our patients tell us it really happened at work?
Fraud is an intentional action. It's not an unintentional action. If we bill something to WorkSafe that ought to be MSP or the other way around without the intent to defraud, that's not fraudulent. I think that actually might be the answer to the question here.
Okay, thank you. If approval for expedited surgery is rejected because the patient's claim is rejected, and the patient goes on to have surgery, and the patient successfully appeals at WCAT, so their claim ultimately does become accepted, WCB should be obligated to notify the treating physician they are eligible for the expedited fee, and they should automatically be sent payment for the expedited rate without having to request it.
That seems very logical. That isn't an issue that we specifically dealt with in the negotiations. I would expect that WorkSafe would do such a thing, but there's no guarantee that I have that they will.
Okay, so that appears to be it for questions. I want to thank everybody very much for attending tonight. Oh, no. Come back, okay. Okay, it happened to me and they did not notify me. And after listening to all the questions, complaints, etc., there are a lot of different issues doctors have with WSBC. It is not possible to cover everyone's specific issue. However, it sounds like the negotiating committee covered a lot of difficult issues. Thank you for a thankless job.
Very much, on behalf of the negotiating committee, I thank you for the recognition, and the other the members of WorkSafeBC that worked hard on this deal. So really appreciate that.
Okay, so we don't have any more questions left in the queue. I don't know if any of you want to say any last words before we sign off.
To the extent that I have a last word, my sense following this round of negotiations is quite optimistic. I did not participate in the last round, but it seemed like it was going to auger into the earth. after the set of negotiations because of the hard feelings that were developed. We left this time thinking they really want to make a difference. And so my hope is, to the extent that there are issues that we haven't specifically addressed, there will be an open-minded approach through the collaborative committees that operate over the term of the contract to see these things, to see the challenges that we've heard about fixed. So my sense is over the next short while, certainly until the next round of negotiations, quite optimistic with respect to WorkSafe as an employer compared to the past.
Okay, thank you. So we just have a few comments. Thank you for arranging this Q&A session. I also thank you for a job well done. Thank you for the work you folks do on our behalf. And the email address for further questions is doctorsofbc.ca.
And it's posted in the chat.
And thanks so much for the work. It makes our life and practices better. Nice to see some light. So I hope you all found this webinar helpful and informative. A reminder that it will be recorded and will be available. We're aiming for tomorrow. And wishing you all a good rest of your evening. Good night to everybody.
Right.